All right, so the second hour, we're going to talk a little bit about sepsis and approach to patients with sepsis in the ICU. And I understand that this is not necessarily the respiratory therapy related topic. So again, I'll try to make this more of a general idea of how we approach sepsis. And then there are some certain guidelines that are more respiratory centric, and we'll try to spend a little more time on those. So again, I have nothing to disclose, and goals and objectives for this one will be to analyze the literature regarding diagnosis and treatment of sepsis, review the recent guidelines on sepsis, discuss the importance of the implementation of these guidelines. This is more hospital-wide implementation, again, perhaps not terribly RT-centric. But I'll start the presentation with this slide that I used in my lecture that I gave as grand rounds in 2018. Back then, we still had grand rounds, the actual grand rounds, when you would go to a hospital and you stand in front of the audience and actually deliver a lecture. And I haven't done that since the pandemic. All on Zoom now, it's all electronic now. Anyway, this was a very sort of interesting slide. I hope you recognize the character from Game of Thrones, and it basically meme used, brace yourself, the antibiotic resistance is coming. I think the original caption was brace yourself, the winter is coming. So in 2018, Game of Thrones was the hottest show on TV, and only virologists talked about coronavirus. You can imagine yourself in 2018, and I'm not sure any one of us used coronavirus very often in our conversation. Anyway, to say that sepsis was probably a very different thing back then, try to kind of channel ourselves back into that as the corona and COVID pandemic is kind of dying down. So we're reorienting ourselves from COVID-related sepsis or sort of general sepsis again, and that's where most of the conversation, most of the discussion will be about today. So there was quite a bit about sepsis. We go back all the way to Hippocrates. I hope you recognize this lovely gentleman here who became very famous based on his intellect and talent, or maybe based on his unscrupulousness. This is Sir Alexander Fleming, who came up with penicillin, either as part of his very dedicated research or maybe as part of his unscrupulousness and inability to properly contain his growing medium. Anyway, from Hippocrates to 20th century, at the change of the century, we had this sort of landmark trial on sepsis by Rivers et al. That revolutionized kind of how we looked at sepsis. Then, partially based on that, but mostly based on the preponderance of literature we had, there was formed this very interesting idea, Surviving Sepsis campaign. So idea was we had just enough information, sort of critical mass of knowledge, if you will, to talk about sepsis and create some guidelines about how we approach sepsis in a evidence-based way. Until then, the sepsis was, someone has an infection, let's give them antibiotics and see how that works out. So now, starting in 2001, we're looking at how we take care of septic patients beyond just giving them antibiotics, more about holistic approach to improve outcomes in an evidence-based way in patients with sepsis. The first came this Barcelona declaration. They got together in Barcelona for whatever reason. I don't know why they chose Barcelona, but in October of 2002, there was the Barcelona declaration that the people will coming up with various guidelines. And the best minds when it comes to sepsis got together and created the guidelines called Surviving Sepsis guidelines. My title to this lecture, Surviving Sepsis in 2024, partially comes from their idea of calling this Surviving Sepsis campaign and then Surviving Sepsis guidelines. If you want to learn more about it, they commonly and continuously publish updates to this every couple of years or so, based on how quickly or how frequently the new information comes out. There was an interesting wrinkle or interesting sort of sidestep to this campaign when a interesting article was published in 2016. They wanted to change how we approach sepsis, and didn't really stick very well. So I'm not going to talk a whole lot about that. The general idea of SIRS criteria and using SIRS criteria for defining someone with sepsis kind of persevered, and sepsis-free and that sort of way of thinking about sepsis has largely gone away. So we're not going to spend a lot of time on that. So I'm going to play the New York Times game, Connections, a little bit. I don't know how many of you play that. I play that game with my family almost every day. So let's see how these three things are common. So we have this little outhouse, if you will, with a tank here that takes everything from the toilet. We have this kind of weird algebraic equation, and we have a critically ill patient with infection. Obviously, the bottom one is septic patient, where what septic means infection. And in the middle, we have septic polynomial, and the word septic actually means the 7th power. So x to the power of 7 is the septic expression. And here on the top, we have, I'm sure most of you have gotten this too, we have a septic tank, where septic is the word, meaning of the word septic is sewage. So if you see this kind of words in your next New York Times connection game, think of sepsis. So why is sepsis so confusing? That we have such a weird and confusing terminology for a relatively common illness. I'm going to show you a couple of memes. I have another handful of memes about this, something that I find and collect as I scour the internet. But here's another meme. If sepsis could be less confusing, that would be great. And you can imagine that based on the previous cartoon that I showed you, and not just the word and definition of the word sepsis, but the idea of the disease sepsis still remains relatively confusing for a lot of individuals, healthcare providers. And then trying to understand sepsis is like trying to smell the color nye. So yes, with some humor attached to it, I think it's important to understand that sepsis is complex and sometimes difficult to understand concept. So let's talk about sepsis definitions. Hippocrates defines sepsis as a process by which flesh rots, swamps generate foul airs, and wounds fester. He probably wrote it in Greek, and this is translated. Then Galen, who was the father of surgery, Hippocrates was father of medicine, Galen is considered the father of surgery, a laudable event necessary for wound healing. So as a surgeon, he was looking forward to inflammation and sepsis because it would help with the wound healing. So you can imagine that a sort of medical or internal medicine or non-surgical individual looks at sepsis as a bad thing, and perhaps surgeon looks at sepsis and inflammation as potentially beneficial thing. And probably Pasteur captured it best as in terms of historical figures describing sepsis. Pasteur said the result of the host's invasion by pathogenic organisms that spreads to the blood. So the more common and more modern definition of sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. And that may be a mouthful too, but let's talk about what it actually can break this down a little bit and talk about what happens to an individual that develops sepsis. What really separates a simple infection from sepsis? So let's say an individual develops simple infection. That individual may have fever, may have some discomfort, and some relatively mild illness. And I think that most of the individuals with urinary tract infection will get over that infection relatively easily, maybe over the period of a couple of days. They may or may not take the antibiotics, probably will, but in general, urinary tract infection is not a major event and is not a whole lot to talk about. So what happens that moves something as simple and as common as urinary tract infection into more ominous, more serious septic category? So everybody that develops an infection develops some type of inflammatory response. And when that inflammatory response is directed, it's kind of honed in to that infection is treated or managed by the host, and maybe the host will require a little bit of help from antibiotics just to get over it sooner rather than later. If that inflammatory response becomes regulated and kind of spreads, not just attacks the organisms in the urinary tract, attacks the urinary tract, that inflammatory response becomes dysregulated and attacks the entire body or spreads all over the entire body, that's basically when we have sepsis. So we have a dysregulated host response to infection. It's okay to have aggressive reaction to an aggressive infection, but regulated, honed into that infection, rather than become dysregulated and affect the entire body. So I may use another little meme to describe the difference between regular infection and sepsis. So immune system asks, is soldier, did you destroy the bacteria? And soldier in this situation is cytokines like IL-1, IL-6, TNF-alpha. The exact name of these cytokines and these soldiers is not really important. But the immune system inquired, did you destroy the bacteria? Yes, we destroyed the bacteria. What did it cost? Everything. The idea is that we want to destroy the bacteria and not cause the dysregulated chaos of sepsis which affect every single body in the organism. I'm sorry, every single organ in the body. So the idea of looking at sepsis is to compare that and think of sepsis like other emergencies. I think over the years, we've accustomed to call MI, myocardial infarction, heart attack. And again, it brings on some urgency to the situation. Someone's having a heart attack, we have to take care of it quickly. Similarly, strokes are now described as brain attack. Okay, again, the idea that the time is myocardium or time is brain tissue, in a sense that sooner we get to someone with heart attack, sooner we get to someone with stroke and implement our treatment, more myocardium we will save, more brain tissue we will save dying. And I think that we have to start thinking about sepsis similarly, and not that this is really a good name for it, but in a sense, we need to think of sepsis as emergency type of situation. Bugs attack, infection attack, or some other way of equating or equalizing sepsis with stroke and MI. And we accept now that patients with stroke and patients with MI need immediate attention. Within 30 minutes, within an hour, we have to give them this and treat them that way and so on. And we have to approach sepsis similarly. Have sepsis gain the emergency status, time-sensitive treatment approach like the other disease. So for that reason, CMS has come up with this 1 hour bundle. So within 1 hour of patient with sepsis presenting to emergency department, or within 1 hour that patient developing, exhibiting symptoms, signs and symptoms of sepsis, various things have to happen. We have to measure lactate level. We have to obtain blood culture before administering antibiotics. We have to then administer antibiotics. We have to start rapid infusion of fluids. And the typical amount of fluids to be infused in these patients is about 30 mL per kg. And then we have to apply vasopressors or pressors, something like Levophed or norepinephrine or dopamine or medications like that to raise the blood pressure, mean arterial blood 65. Again, you may say, what does this have to do with the respiratory therapist? But if we're talking about sepsis in general, this is the things that many hospitals will hone in, because then CMS, Medicare will look at the hospital and rate the hospital based on their ability to properly take care of septic patients. So hospitals will place a lot of emphasis and a lot of effort to make sure that all these things within the 1 hour bundle are done properly. But to simplify things a little bit, the 1 hour bundle elements are measure lactate level, obtain blood culture, antibiotics, administer broad spectrum, begin rapid administration of fluids, and apply vasopressors to increase blood pressure. And then the other one is to remeasure lactate. If initial lactate was elevated, we need to remeasure the lactate and make sure that the lactate comes. This is one of the ways that CMS, when it comes to evaluate your individual hospital, will look at whether or not all patients with sepsis has undergone the bundle. And if some of the bundle parts are not implemented, then that's going to result in some kind of citation or negative event. Many hospitals will be very, very attuned to making sure that all these various bundle criteria are. And it's not just bureaucracy. It's not just CMS coming up with something that's complex and difficult to achieve. If we look at the SEP1 bundle or 1 hour sepsis bundle implementation over a large group of patients, this is all CMS data, you will see that the patients that completed the bundle, significant improvement in their compliant versus non-compliant patients. Compliant patients had 20% or so reduction in their mortality compared to non-compliant patients. What's perhaps more important from this particular database is the following. The pass rate of all the individuals, all the patients, 333,000 patients. What's the total pass rate? How many times, what percentage of those patients truly receive top-of-the-line treatment for sepsis? About 40%. So it's not to say that 30% should be the goal, or 50%, which is better than this, should be the goal. But the idea is that we need to do better in terms of being compliant with 1 hour bundle. Moving away from that a little bit and talking about surviving sepsis guidelines, which were the last version of the surviving sepsis guidelines, were sort of developed in 2021 and eventually published in Critical Care Medicine Journal. There were a total of 93 statements that these individuals make. So this was a group of 50 or so physicians and other healthcare workers, not just a group of 50 sort of the experts, leading minds on sepsis. They got together and they said, what can we say about treatment of sepsis? How many of these statements can we evaluate and say this is a good thing to do or this is not so good? So a total of 93 statements were issued, okay? Commandments, if you will, right? 10 commandments. 93 statements were issued, and each one of them received grading, meaning we are really sure we know this. If that's the case, based on, again, evidence-based medicine and studies, etc., if they were sure that there was strong support for that particular statement or that particular intervention, They gave it a strong grading. Weak grading was obviously a little bit lower than that. And then the other things were best practice statement, which basically means, well, we think that this kind of works. And then there are at least 9 statements that they had no recommendation. Well, this is an important thing. This is the important intervention in sepsis. We just don't know what. So out of 93 statements, 15 were strong statements, meaning we're sure this thing works. 54 were weak, and so on. Okay. There was a whole separate section on ventilation. So what I'm going to do in the next 10, 15 minutes or so, go through all statements that had strong support from surviving sepsis guidelines. And then go through all statements that were on ventilation, because ventilation is something that's more germane to us. And probably not mention all 93 of them, but like I said, mostly talk about strong recommendations and then discuss the recommendations on ventilation. So I'll number them the same way that they were numbered in that particular article, Surviving Sepsis Campaign, Critical Care Medicine, 2021 issue. So statement number 1 for hospital, and this, all of the statements that I'm going to mention in the next few slides were strong recommendations. We're sure this works. We're sure this is the way to do things. Hospital and health systems, we recommend using a performance improvement program for sepsis, including sepsis screening for acutely ill, high-risk patients, and standard operating procedures for treatment. Basically saying, here's our guidelines, please implement them, and also have a way to identify patients with sepsis and properly treat them. I'll give you our experience in our hospital. We actually have a thing called Code 7. When a patient comes in, and the patient has signs and symptoms of sepsis, these patients are encountered in the emergency department, but sometimes on the floors and sometimes in the ICU too. We announce throughout the entire hospital, we announce Code Sepsis, emergency room number 10, or Code 7, unit, 4 West, room number 400. So that means that team of healthcare workers, physicians and nurses and respiratory therapists and everybody else in between, rushes to that area to make sure that the patient in that room receives the appropriate treatment for sepsis. The appropriate treatment may be fluids, antibiotics, maybe arterial blood gases, maybe intubation. There are multiple iterations of what the patient needs. And again, the idea is that we think sepsis is emergency, like MI is an emergency, stroke is an emergency. So similar to code MI, and we have code STEMI in our hospital. We have code stroke in our hospital. Again, the idea of code STEMI and code stroke is patient is having trouble, needs immediate attention. Let's rush everyone to his or her bedside. And the same idea applies to. I think I have some slides to show how implementation helped us in our hospital improve our compliance one bundle. In 2020, the beginning of 2020, you can imagine sort of craziness was happening in 2020 with the pandemic and everything else. So perhaps these are not the best numbers to start with, but you see a clear climb in terms of bundle compliance in our hospital. And I think that implementing that helped with this dramatically. Another one that I think is not well represented on this slide, another important outcome of the code implementation in our hospital was to look at our compliance rate with SEP1 bundle. As the compliance rate went down, and I think here you can see the changes in the compliance rate. But as the compliance rate went down, mortality from sepsis went up, and vice versa. As the compliance rate with the SEP1 bundle went up. Okay. Our hospital, the healthcare workers in our hospital were shown the data that based on the compliance, we can change, make difference, and I think that was one of the biggest sort of motivating factor for those individuals to be a better participant, get stronger bundles, our compliance rates up. I won't spend much more time on that, just to show you that compliance with those one bundle is very, very important in determining the overall outcome. Another general recommendation, we recommend against using Q-SOFA compared with SIRS, NEWS, or MUSE as a single screen. And this may sound like I'm speaking another language to you, but Q-SOFA in 2016 to maybe 2018, Q-SOFA was this new sexy thing that we thought was much better than SIRS. But basically, SIRS is probably just as good, if not better, than Q-SOFA. And because most everyone is familiar with SIRS, the Surviving Sepsis Guidelines, individuals thought that SIRS should be used over Q-SOFA and not the other way around. I think the whole idea of SIRS versus Q-SOFA was more about the sensitivity and specificity of these tools to diagnose patients. The idea is that SIRS is a lot more sensitive, but not as specific to diagnose someone with sepsis. SIRS captures a lot of patients. Use SIRS as the diagnostic criteria for sepsis, but we'll realize that the SIRS captures a lot of, and maybe a small percentage of those patients will not. But the idea is that we want to catch everyone. So if you can imagine, if Q-SOFA, SIRS is the yellow, you will catch a lot of patients without the disease, but you'll be sure to catch everyone with disease. Alternatively, if you use Q-SOFA as the screening criteria for sepsis, you're going to catch everyone. You're going to make sure that everyone with Q-SOFA has sepsis and nothing else. You may miss a chunk of patients. The idea of SIRS being better than Q-SOFA, the whole idea of SIRS is it's more encompassing, and it may catch the patients that don't have sepsis, and that's okay, because it will at least catch all the patients with sepsis. And it's okay to call sort of code sepsis on those individuals. And that generated a few more moves. Okay? So this patient is a sepsis alert. Well, the rate is only elevated because they had a seizure. Seizure can elevate. And it goes back and forth. They meet the criteria. Well, it's not sepsis. But the idea is that we want to catch them, as many of them as possible, and treat them as aggressively as possible. And maybe a small percentage of them will end up not having sepsis, but that's okay. At least we everyone. And it's very much similar like patients with MI. In many situations, we'll look at the EKG and we say, well, this doesn't quite look like MI, but I don't want to miss the MI. So let's take this patient to the cath lab and do the catheterization, look at his vessels and see if there are blockages. If there are no blockages, it's okay. Cardiac catheterization is not such a bad thing. At least we make sure that we did not miss the MI. And in many ways, approach to sepsis is similar to that. Let's make sure that we don't miss the sepsis. Make sure that we capture every patient with sepsis, treat them aggressively with the proper management. And if a small percentage of those patients that receive the sepsis treatment turn out not to have sepsis, it's okay. We really haven't done a whole lot. So shifting gears a little bit, obviously antibiotics will play a big role in management of sepsis, and it's recommended that for adults with possible shock or high likelihood of sepsis, we recommend they receive antimicrobials immediately or ideally within 1 hour recognition. Again, this is one of the strong recommendations, well, or commandment number 12. Next one is about choice of fluids. We're going to have a couple of words about choice of fluids towards the end of the presentation. But the general idea is that we want to use crystalloids, things like saline, lactated ringers, and not some other fancy solutions like albumin or starch. Or basically, use normal saline or lactated ringers for volume. Hemodynamics. For adults with septic shock, vasopressors, we recommend an initial target of MAP greater than 65. That's pretty simple and straightforward. I'm sure you have encountered this with patients in the ICU that we often apply vasopressors. For adults with septic shock, we recommend using norepinephrine as the first-time agent over other vasopressors. So idea is we want the blood pressure on these patients to be greater than 65, mean arterial pressure to be greater than 60. The idea is that we don't want them to receive pressors early on. We want them to have a reasonable chance to improve their. Only when fluids are not enough to achieve the proper dynamics, we may add a little bit of vasopressors. Old Bay will come in with just a little bit of the touch of vasopressors, the right amount of vasopressors. So the idea is that we want to manage them with fluids only when needed, just a touch of vasopressors. A couple of other strong recommendations: use restrictive transfusion policy, use DVT prophylaxis unless contraindicated, meaning heparin or heparin-like medications. Use low molecular weight over unfractionated heparin prophylaxis, and initiate insulin therapy to keep glucose. Some of this seems elementary and probably doesn't even need to be repeated or discussed why this isn't. So let's dive a little bit deeper in terms of vent management, and let's see what they recommend in terms of vent management. A total of 12 statements were made on ventilator management. And if you look at the article, those were statements number 46 to 57. 4 of them were strong recommendations. 2 of them were weak recommendations. And 2 of those statements, they really had no recommendation. Let's examine them one at a time. And for strong recommendations, I'm not going to tell you anything that you don't know already. Use low tidal volume, 6 ml per kg of ideal body weight, obviously. Keep plateau pressure below 30 centimeters of water. Yes. Do not use incremental PEEP as recruitment maneuver. So they're not necessarily recommending against recruitment maneuver, but don't crank up PEEP as your recruitment maneuvers. Use other types of maneuvers, more honed in recruitment maneuvers for cranking up. And use prone ventilation for at least 12 hours in patients with moderate to sepsis. I probably haven't told you. These were the strong recommendations. Let's look at the rest. And again, I'll use the same numbering they're using in the article on surviving sepsis. Number 46, there is insufficient evidence to make recommendation on the use of conservative oxygen targets in adults with sepsis. So to say, use supplemental oxygen, use liberally, we don't know whether we should give them just a smidge of oxygen or put them on ton of oxygen. It's no recommendation. It's not enough. We don't have enough information. Number 47, for adults with sepsis-induced hypoxemic respiratory failure, we suggest the use of high-flow nasal oxygen over non-invasive ventilation. And this was a weak recommendation. There was a relatively low quality of evidence. And this recommendation was this was new in 2021. They didn't mention this in the iteration of the guidelines. This was new. Maybe use high flow nasal cannula over non-invasive ventilator, but we're not 100% sure. There's low quality of evidence to support that high flow cannula is better than non-invasive. Number 48, there's insufficient evidence to make a recommendation on the use of non-invasive ventilation in comparison to invasive ventilation for adults with sepsis-induced hypoxemic respiratory failure. So there are some diseases that we know that non-invasive ventilation is better than invasive ventilation, like BiPAP versus intubation. Sepsis, it's not one of those. We don't know whether or not BiPAP is indicated. Use your clinical judgment. There was no recommendation. I skipped a couple because they were discussed as strong recommendations. So we go to 51. For adults with moderate to severe sepsis-induced ARDS, we suggest using higher PEEP over lower PEEP. So if you're dealing with patients with ARDS, they're probably better off with high PEEP, low PEEP, but it's a weak recommendation and the quality of evidence was moderately good. So probably a good idea, but they didn't think that there was enough evidence in the literature to make it. Number 52, for adults with sepsis-induced respiratory failure without ARDS, we suggest using low tidal volume as compared with tidal volume ventilation. So I don't know why this did not reach the strong recommendations, because we use low tidal volume ventilation in just about everyone with or without ARDS. But I think they were strict about how they make their recommendations. So they called it a weak recommendation. And I apologize, I didn't go here. So they used it as a weak recommendation and low quality evidence. I think just a couple more left for the vent management as it applies to septic patients. Adults with sepsis-induced moderate to severe ARDS, we suggest using traditional. Again, weak recommendation, moderate quality of evidence. They said don't use PEEP, but use other typical traditional. Number 56, again, we skip a couple because there were strong recommendations on discussed them early. For adults with sepsis-induced moderate to severe ARDS, we suggest using intermittent neuromuscular blocking agent boluses over continuous infusion. So there is some debate whether or not paralytics, Nimbex, or other types of paralytic medications works in ARDS. Fortunately, there was only one study published 15 years ago or so, suggested small single-center study that suggested that neuromuscular blocking agents like Nimbex are beneficial in patients with ARDS. Those studies were not repeated, and use of neuromuscular blocking agents has not become the standard of care in sepsis-induced ARDS patients. However, if you decide to use the paralytic agents, use boluses, not infusion, it's a weak recommendation with moderate quality. Number 57, for adults with sepsis-induced severe ARDS, we suggest using veno-venous ECMO when conventional mechanical ventilation fails, but only in experienced centers with infrastructure in place to support. So for places like my hospital, we don't have ECMO. Obviously, we cannot deliver ECMO to our patients. So many situations we have to transfer our patients to another hospital for ECMO. But I think in general, the evidence for ECMO in sepsis-induced ARDS is relatively weak. Therefore, this particular iteration of guidelines also received weak recommendation, low quality of evidence. There was also a new recommendation. So that's sort of the end for sepsis, surviving sepsis guidelines. And I want to kind of go over a couple of other things that you may have heard discussed in various circles, whether it's New York Times or Washington Post or LA Times, whether it's some national conference that may discuss new treatments for sepsis. So I'll try to, in the next 10 minutes or so, 10 or so, go over some of those other disputed topics and give you at least my opinion or my interpretation of literature out there. We specifically going to discuss a couple of topics. Number one, amount of fluids to be administered to patients with severe sepsis and septic shock, choice of fluids to be administered, so normal saline versus lactate bringers, etc. And then vitamin C. Hopefully the debate is over for vitamin C, but I'll give you a couple in my this. So I made this slide about a year ago when ChatGPT was the hottest thing in the world. And I don't know if you can appreciate why certain words and certain letters are in capital, and the rest of the letters are actually in lowercase. The reason for capitalization in this particular sentence, if you will, is that the words that are capitalized are names for certain studies that addressed patients with sepsis. Lovett, Classic, Clover, Petal, Plus, Basics, Split, Smart, Salted, and Citrus are all names of various studies that approached or addressed various types of treatment. Obviously, we're not going to discuss all of them here, but like I said, I'll touch upon a few things that may be important in terms of understanding how we treat patients with sepsis 2024. Again, what I say today may be upended by another new study tomorrow, but at least this is the state of evidence in as of May 16, 20. So here's me channeling my inner Bernie Sanders, and he says, I'm once again asking for your support to stop fluid overloading septic patients. So the idea behind this statement is the following. I'm sure we all know very well that septic patients, when they come to the hospital, they require a significant amount of IV fluid, typically 30 mLs per kg. So in many individuals, that's 2, maybe 3 liters of fluid. And sometimes that amount of fluids is enough to replace their circulating volume. It is enough to get their blood pressure up, is enough to make their kidneys work better, et cetera, et cetera. Sometimes it's not. You need to put those patients on pressor agents. A lot of times what happens is that placing patient on pressor agents like Levophed or dopamine or something similar is considered some type of failure. I failed this patient. I couldn't get his blood pressure up. I couldn't get him better with IV fluids. And now I failed and I'm giving. Or alternatively, they'll use the word failed normal saline treatment, failed volume expansion, like it's a terrible thing to have. Well, and those patients continue to receive large amounts of fluid above and beyond what's recommended, 30 mLs per kg. So after receiving 2 liters, blood pressure doesn't receive another liter, so on until we reach some unnatural, non-physiologic levels of volume infusion, 5, 6, 7 liters infused within the first day or so, and the patient still requires pressors. Except now we've overloaded that individual with lots of fluids. That's going to come back and be deleterious because that patient can develop CHF, pulmonary edema, worse oxygenation, ARDS, et cetera, et cetera. So I think that there is some happy medium, kind of like Goldilocks event. Not too little, but also not too much. So how much is too much, really? And there are a number of studies that show that standard fluid group, after delivering the bolus amount of treatment, standard fluid group did not do any worse or any better than restrictor fluid. So don't overload your. Clovers is another similar study that showed that aggressive fluid resuscitation after receiving appropriate amount of bolus was no better than standard fluid. So study after study shows that giving patients excessive amount of fluids after what's recommended, after initial 30 mLs per kg bolus, After that's in, giving them more fluids is not necessarily better. Now, raise your hand, if you will, if you recognize this particular individual, and more importantly, why do you think that I have him here? Well, this is John Lovitz, who was recurring character on Saturday Night Live, probably in the 80s and 90s. And he always was a sort of a snake oil salesman, was pushing something, advertising something, selling something that was probably not too good. And I bring him on because I feel that vitamin C for sepsis is similar to John Lovitz and his character on SNL. And there was a study published in Chest in 2017 by Dr. Merrick and his co-workers that somehow showed that individuals that received vitamin C did better than individuals that received control individuals or individuals that received treatment. Here we have treatment with vitamin C. Actual mortality is much lower. Here we have control group, and mortality is basically unchanged. Somehow everybody says, oh my God, vitamin C is such a good thing. Patients, unfortunately, that did not pan out when we used randomized placebo-controlled large trial, and 1,000 patients were recruited, and the study was published in the New England Journal of Medicine and kind of put the kibosh, if you will, on treatment patients with vitamin C. And I won't bore you with a lot of details of the study. Suffice it to say that patients receiving placebo did slightly better, certainly no worse than patients. So with that, question about vitamin C kind of very abruptly, and surviving sepsis vitamin C. The next interesting discussion is more about the choice of fluids to be used for initial fluid resuscitation. And the discussion is about normal saline versus lactate. And how come that on my slide on normal saline versus lactate ringers, I'm talking about something a lot more philosophical, a lot less medical. And again, I have a little meme here of comparing Batman to Superman. And I'm sure if you were a teenager not too recently, or if you have teenage children or grandchildren, you probably heard of this discussion: who is better, who is stronger, who is a better superhero, Batman or Superman? And the discussion about normal saline versus lactated ringers, to me, mimics that. And I could talk about this for many, many hours, but unfortunately, I only have a couple of minutes, and I think I only have a couple of slides on this. So the debate about balanced crystalloids, something like lactated ringers versus saline in critically ill adults. So if you've looked at some studies with the critical eye, you will know that when we look for good articles, when we look for good studies, we want to hear words randomized, blinded, placebo controlled. Randomized, double-blinded, placebo-controlled study. That seems to be like the epitome properly done. So now we're going to talk about balanced crystalloids versus saline in critically ill adults. And listen or look for those big words: randomized, double-blinded, placebo-controlled, as I described this study. Pragmatic, clustered randomized, multiple crossover, unblinded, conducted in 5 intensive care units at a single academic. So if you're looking for the ideal study, this ain't it. Let's review the results of this. Here, the study touts that it's so much better in terms of chloride concentration. The patients that received saline had chlorine concentration, average chloride concentration somewhere between 104 to 106, as compared to the individuals that received balanced crystalloid, whose chloride concentration was somewhere between 103 and 104. I hope your jaws dropped, because mine didn't. Nice. Oh, this dramatic difference in chloride concentration, okay, that went from 103 to 104 to 104 to 104. There may be some statistical significance to that, but I see no biological to that. And similarly, the study says, well, bicarbonate levels were better in patients receiving balanced crystalloid. The difference was less than 1 unit in bicarb concentration. The bicarb went from somewhere in the 20-24 range to 24-25 range. Again, maybe statistically significant based on the p-values, but I wouldn't care very much about my patient bicarb. There was some difference in these patients, but there was no difference in hospital mortality, ICU-free days, ventilator-free days, vasopressor-free days, RRT-free days, that's a dialysis-free days, or creatinine level. But somehow it was thought that the patients with balanced crystalloids did better than patients with normal saline. You make your own conclusions. Here are the conclusion of those trials as they were published in New England Journal of Medicine and Blue Journal, American Journal of Respiratory Critical Care Medicine. Let's read the conclusion. In conclusion, in this trial involving critically ill adults, intravenous administration of balanced crystalloids rather than saline had a favorable effect on the composite outcome of death, new renal replacement therapy, or persistent renal dysfunction. Not too bad, but remember that the design of the study was not, just forget ideal, was not proper. Among patients with sepsis in a large randomized trial, use of balanced crystalloids was associated with a lower 30-day in hospital mortality when compared with use of saline. So this was only secondary analysis of the SMART trial. This was the first excerpt was SMART trial. This was from the secondary analysis of the SMART trial. So this kind of evoked some of my favorite expressions about statistics. Torture the numbers long enough, and they'll tell you what you want to hear. And they use the data like a drunk uses lamppost for support, not elimination. So I think that you kind of get some sarcasm or some criticism of these studies that tout that the balanced crystalloids are better than normal saline. I'm not a big believer. I don't buy that, but there is some weak evidence that balanced crystalloids are better than normal saline. When it comes to that, I'll leave you with this excerpt. Balanced versus normal saline meta-analysis that included 13 trials. There was some bias, but the overall statement was overall impact on mortality based on these 6 trials out of 13 that had low risk of bias. The overall impact on mortality out of these 6 trials was a reported relative risk of 0.96 with a confidence interval of 0.91 to 1. For those of you who may not be very familiar with statistical analysis, absolute risk reduction was about 1%, so 1% improvement in survival. Number needed to treat was about 100. You have to treat 100 patients with this backdated ringers over normal saline to improve one outcome. There was minimal biological significance again, and arguably no statistical significance because this interval crossed over 1. Okay, and here was their conclusion. In this systematic review and meta-analysis, the estimated effect of using balanced crystalloid versus saline for fluid therapy in critically ill adults ranged from 9% relative reduction to a 1% relative increase in risk of death by 90 days. Okay, I like the other statement. Again, if you want to skip over the complex language of the statistics, the inferences drawn from our study will depend on individuals' preference for a frequentist or Bayesian approach to interpreting data. So you're basically telling me that I'm going to interpret the data of the study based on my personal beliefs and not based on the evidence. that doesn't make the study very strong. So that's kind of my take on it. You make your own conclusions. I think I have just exhausted my time on this, and I think that we're kind of nearing the end of my presentation. So some disputed topics, so the take-home point for the disputed topics is beware of enough is enough moment in terms of fluid administration. When it comes to choice of fluids, LR is probably, well, definitely maybe better than normal saline, but more convincing studies are needed. And when it comes to vitamin C for sepsis, multiple well-designed studies. I'll leave you with a little bit of summary on surviving sepsis in 2024. Treat sepsis as an emergency. Early recognition and aggressive goal-directed therapy will save lives. Follow SEP1 guidelines because it's not just the CMS rule, but also saves lives. And use fluids judiciously. Choose carefully the type and amount of. I think just about everyone will agree with 30 mL per kg of fluid administration as a bolus, whether it's normal saline or lactated ringers, that's up. And don't be shy to use vasopressors. Again, that may not be necessarily something that you as respiratory therapists will be choosing, but I'm trying to give you sort of general approach and general overview of sepsis as a whole. And probably the first statement that I made about sepsis, that fluids and antibiotics remain the mainstay of therapy, is still true. So I think with that, I finish my slides, and I apologize for running over just a little bit. Kind of tend to do that just by a couple of minutes. And I'll be happy to take your questions either verbally by asking that in or putting that in chat.